Hey everyone, and welcome back to Mastering Medicine video lectures. Today we're going to discuss megaloblastic anemia or vitamin B9 and vitamin B12 deficiency anemia. So, in this first part, we will discuss metabolism of vitamin B9 and vitamin B12. Okay, because this part is very important for perfect diagnosis and differential diagnosis and of megaloblastic anemia, and also to know about the etiology and treatment of megaloblastic anemia. Okay, so during this lecture, first of all, we'll talk about folate or vitamin B9 and cobalamin or vitamin B12 absorption, then its metabolism, then its biochemistry, plus its related some clinical points. Okay, and in next part we will talk about pathophysiology of megaloblastic anemia, causes or etiology of megaloblastic anemia, pathogenesis, sign and symptoms, and diagnosis, differential diagnosis, and treatment of megaloblastic anemia. Okay, so first is first, let's talk about folate or vitamin B9. First, folate or vitamin B9 is a water soluble vitamin, okay, or it's sometimes called hematopoietic vitamin also, okay, because it has role in RBC production or hematopoiesis. We have two terms, one is folate and one is folic acid. They're used interchangeably, but there's a bit difference between these two terms. Folate is called for the natural vitamin B9, and folic acid is called for the synthetic form of vitamin B9 that we use it in treatment of megaloblastic anemia. Okay, plus sometimes folic acid is also called steroid glutamic acid. Okay, now the word folic or folic acid is taken from the folia, and folia means green, okay, or green vegetables. We can find the folate and folic acid in leafy uh, greens plus liver and so on. Okay, now folic acid or folate is made of three components, made of three things. First, it's made of pyridine ring. Second, it's made of para-aminobenzoic acid, or it's a vitamin-like substance. Plus, it's made of an amino acid which is called glutamic acid. Okay, you can watch the photo or structure of this folate or folic acid in the photo. Okay, now in the diet, okay, in the diet, which is called folate, okay, or dietary folate, we have two types of folate. First, we have polyglutamic type or form of folate. Second, we have monoglutamic form of folate, but synthetic form is monoglutamic folic acid. Got it? Now let's talk first of all about the absorption of folic acid or folate. Now, when we eat folic acid or folate, okay, it comes to stomach. Then from the stomach we have duodenum, first part of small intestine. Then we have jejunum. Then we have jejunum. Okay, so in first part of jejunum, where the pH is around 5.5, okay, and it's a bit acidic. Okay, so here this is the place for digestion and absorption of folic acid. Now I'll zoom this part of jejunum, okay, here. So this is lumen or jejunum here, and here, because jejunums are made of cells, so this is called intestinal cell or jejunal cell. Okay, so this is lumen of jejunum. Now when we take folate or folate, specifically polyglutamic type of folate, plus we have some proteins and some other things around it. Okay, so first of all we will digest it. Okay, now we have this polyglutamate form. We cannot absorb polyglutamate form of folic acid. We have to change polyglutamate form to monoglutamate form. Okay, so when you want to change polyglutamate form to monoglutamate form, we change it in jejunum, and in jejunum we use an enzyme. The enzyme is called folate conjugase. The enzyme is called folate conjugase. Okay, or sometimes it is called gamma glutamate hydro gamma glutamate gamma glutamyl hydrolase. Got it? So now this is folate conjugase enzyme in jejunum. Now after conversion, the polyglutamate form of folate to monoglutamate, now we can absorb it. So now first we have to change polyglutamate to monoglutamate, and monoglutamate is already ready to for absorption. Okay, and also the synthetic form is also ready for absorption. We do not change monoglutamate form of folate to any other forms. Got it? Now here we have in this cell, in this jejunal cell, here we have a transporter. Okay, the transporter is called protein coupled folate transporter, or PCFT. So now it will transport this monoglutamate folate or folic acid inside the jejunal cell. Now we have here monoglutamate folic acid or folate. So now inside the jejunum we have two types of folate. One is monoglutamate folic acid, which is synthetic form. Another one is monoglutamate folic acid, which is natural form. Now keep it in your mind that most of the natural monoglutamate form of folate is in the form of 5-methyl tetrahydrofolate. And keep it in your mind that we can transport this 5-methyl tetrahydrofolate into the blood circulation, and from the blood circulation to the target tissue. Okay, the other forms of folate are not transportable. Okay, we can only transport this form. So we need to change this monoglutamate form to this 5-methyl tetrahydrofolate. So here is some steps, and these steps are so important because we have a lot of drugs that defect these steps one by one, and also mutation in these steps in these enzymes causes folate deficiency, or and literally causes megaloblastic anemia. Okay, so first is first, let's convert this monoglutamate form of folate to different forms of folate, because we use different forms of folate for different purposes in our body. Got it? So now uh, monoglutamate, when you want to change monoglutamate to natural or to 5-methyl tetrahydrofolate, you will go through these steps. First, we will change monoglutamate into dihydrofolate. Okay, we will add some hydrogen atoms on this. Okay, so here in this process, we will change NADPH into NADP, and the enzyme is called dihydrofolate reductase. So first, you will change monoglutamate to dihydrofolate by the enzyme dihydrofolate reductase. So here we have some drugs. Okay, for example, methotrexate trimethoprim. The drug methotrexate is an anti-cancer drug. Okay, it's used for the treatment of cancer. So because literally we will see that when we don't have folate, okay, we will not make new cells, and in cancer cells are developing so much, so we prevent from cell cycle, from cell development and cancer. So this is called methotrexate. It's used in low dose in arthritis. Got it? or rheumatic, or I think rheumatic arthritis. Now we will change dihydrofolate into, we will add more hydrogen atoms to it. We will change dihydrofolate into tetrahydrofolate. And once again, the enzyme is called dihydrofolate reductase. Okay. Now, and also here we use NADPH into NADP. We convert it. Now, this step is very important. Now we will convert tetrahydrofolate to other types of folate because these other types are so important. The folate is also called one carbon. It has rule in one carbon metabolism or in transportation of one carbon. For example, CH3 methyl. This is a one carbon group. Okay, and for example, CH2. These are called one carbon groups. But well, anyway, now come here. I'll tell you the purpose of this one carbon later on. Don't worry. Now we will change tetrahydrofolate to a type of folate which is called N5 N10 methylene tetrahydrofolate. So here the enzyme is called, first of all, in this reaction we have to change an amino acid which is called serine to glycine. Okay, next here in this step, in conversion of this step, to pass this step, we need a cofactor which is vitamin B6. Okay, so the enzyme is called serine hydroxy serine hydroxy methyl transferase. Okay, or I think it's a serine hydroxyl methyl transferase. Okay, now here, now we have in 5 in 10 methylene tetrahydrofolate. Now we can convert 5 in 5 in 10 methylene tetrahydrofolate to 5 methyl tetrahydrofolate, which is transportable in blood circulation. Plus we can convert this in 5 in 10, this is very important, in 5 in 10 methylene tetrahydrofolate to another form of folate which is called in 5 and methynyl tetrahydrofolate. This is methylene tetrahydrofolate. This is methynyl tetrahydrofolate, and the enzyme is called methyl tetrahydrofolate dehydrogenase. Now, now we can change in 5 in 10 methynyl tetrahydrofolate to two other forms of folate, which are called in 10 formyl tetrahydrofolate and 5 formyl tetrahydrofolate. Now, this is very important. We use intane formyl tetrahydrofolate for production of purine, which are called adenine and guanine. So it means in DNA we use 4 nitrogen bases: adenine, guanine, thymine, cytosine. Okay, so for synthesis of adenine and guanine we need folate. If we don't have folate, we cannot make purine. If we don't have purine, we cannot replicate our DNA. We cannot make new DNA from previous DNA, and we cannot make new cells. So this is very important. And 5-formyl tetrahydrofolate is also called folinic acid, and it stores in our body, and we can reuse it. Okay, so the enzyme here is called methynyl tetrahydrofolate cyclohydrolase, and here it's called methynyl tetrahydrofolate synthase. Got it? Now come here. This step is also very important. Now, one way we can change in 5 in 10 methylene tetrahydrofolate to 5 methyl tetrahydrofolate, which is transportable, and we will talk about it. Second, we can change in 5 in 10 methylene tetrahydrofolate to these forms of tetrahydrofolate. Thirdly, we can change in 5 in 10 methylene tetrahydrofolate back to dihydrofolate. So when we want to change it back to dihydrofolate, this is a very important step. Here we will change deoxyuridine monophosphate into deoxythymidine monophosphate. Okay, and later we change this deoxythymidine monophosphate to deoxythymidine triphosphate, and this is another nitrogen base. Okay, adenine, guanine, thymine, and cytosine. So we need to make this. So we need folate to make different types of nucleotides. So this step is very important. The enzyme in this step is called thymidylate synthase. Here also we have some anti-cancer drugs that block thymidylate synthase enzyme. Got it? And here we also change FADH2 into FAD. Got it? This step is also very important. Now come here. Now this type, which is called 5-methyl tetrahydrofolate, and also here we had 5-methyl tetrahydrofolate. Now this type is transportable. Okay, so first of all, the enzyme which transports the 5-methyl tetrahydrofolate, and it enters the this type of folate into the blood circulation. The enzyme is called multi-drug resistance protein, or MRP, and RFC. So it's transported by this protein inside the circulation, and then from the circulation we can transport it to the target cell. For example, this is an RBC, so we can transport it to the inside of RBC by transporters FR2 or folate receptors type 2, type 3, and also F or C. And now we have this type of folate, which is called the 5-methyl tetrahydrofolate, inside the target cell or inside the RBC. Got it? Then we will see that how it has role in RBC production. Okay, in a minute. Yeah. Now we will leave it here. Now come here to vitamin B12, because I want to bring vitamin B12 also here, and we will check that how vitamin B12 and vitamin B9 together work and they produce RBC. Now about vitamin B12. Vitamin B12 is also called mecobalamin. Okay. Now it's also called anti-pernicious anemia factor, or vitamin. Why? Because pernicious anemia is a type of anemia in which stomach cannot produce intrinsic factor. Okay, we'll talk about it. So now those people who cannot produce intrinsic factor, they also cannot absorb vitamin B12. So in previous, doctors thought that when a patient or a person have mecobalamin or vitamin B12 inside his body, so he will not produce pernicious anemia. That's why this is also called anti-pernicious anemia factor. Plus, it's also called extrinsic factor of Castle, because to prevent from production of pernicious anemia, okay, in a patient, so we need two factors. One should be intrinsic factor from the inside of the body, one should be extrinsic factor, and the extrinsic factor is this vitamin B12. Got it? So now about mecobalamin. Structurally, it's made of one ring-like structure, which is called Corin ring. For example, this ring-like structure is called this ring-like. This is called Corin ring. Corin ring is made of four pyrrole ring. This is one. This is two. This is three. This is four pyrrole ring, like him in hemoglobin. Okay, but with a bit difference with the him. Now in center of this green ring, we have an atom which is called cobalt atom. So this the word mecobalamin is originated from cobalt. Okay, and also we can find cobalt in nature, in soil, in rocks also. So like in hemoglobin, in him we had ferric. Okay, ferric. So here we have ferric, I think, Fe2 plus. Okay, so here we have cobalt. Got it? So now this cobalt has 6 bonds. It's connected to four pyrrole rings by nitrogen bonds, and also to the nitrogen areas, and also it's connected superiorly to inferiorly to uh, di this is, I think, this is dimethyl benzimidazole. Inferiorly it's connected to dimethyl benzimidazole, and superiorly it's connected to an R group. This is very important. Okay, to a ligand. Now the name of vitamin B12 or cobalamin is dependent to this R group. If I put OH group here, so this is called hydroxycobalamin. OH group. If I attach here methyl group, so this is called methyl cobalamin. If I attach here cyanide group, so this is called cyanocobalamin. So if I attach here, for example, adenosyl group, so this is called adenosyl cobalamin, because this hydroxyl group, we can find hydroxyl cobalamin in nature, okay, and it's also used in injections, therapeutic goal, okay, and also this methyl tetrahyd or methyl cobalamin or mecobalamin and adenosyl cobalamin, they act as a coenzyme in our body, okay, and also cyanocobalamin, this is also prepared in synthetic form, and you can use it for the treatment of megaloblastic anemia or for the treatment of vitamin B12 deficiency, okay. Now come here to the absorption of vitamin B12. First is first, okay, when we take a vitamin B12, so this is, for example, this red one is vitamin vitamin B12, okay, and around the vitamin B12 we have a lot of proteins and so on, a lot of other substances, okay. So now when we take it, okay, in this time our salivary gland produces a protein like structure which is called cobalo cobalophyllin, or it's also called or binder, or binder, and it's also called heptocorrin. Got it? Now both of them, vitamin B12 plus cobalamin, come to the esophagus. From the esophagus it comes to the stomach. So this is our stomach, okay, this part is our stomach. So inside the stomach, this HCl plus a lot of enzymes, okay, they will degrade this extra part of the vitamin B12, okay. So now vitamin B12 is free, okay, now we have free vitamin B12 inside the stomach. So to prevent from its degradation, we need this R binder, we need cobalamin. So it will join immediately, and it will surround this vitamin B12, okay, and it prevents from degradation of vitamin B12. And now we have vitamin B12, vitamin B12 plus this cobalamin. Got it? So now all of them will come to the duodenum, okay, jejunum, not jejunum, to the duodenum, to the first part of small intestine. So here, by the help of pancreatic enzymes, okay, this R binder or this cobalamin will be degraded, okay. So it's degraded by the enzyme trypsin, okay. So in chronic pancreatitis and in disease of pancreas, we cannot absorb vitamin B12, okay. And also long-term use of PPI like omeprazole, esomeprazole, lansoprazole, and also metformin, they inhibit the degradation of extra parts of vitamin B12 when we cannot absorb it, okay. So now in this time stomach produces an a protein which is called intrinsic factor. This is very important because it is produced by a cell in stomach which is called parietal cell. This is called parietal cell. Parietal cell produces two things. Uh, it makes, for example, for as HCl shortly, and it produces intrinsic factor. So now this vitamin B12 plus cobalamin is followed by intrinsic factor, and in the duodenum, when trypsin degrades this cobalamin. So after its degradation, to prevent from destruction of vitamin B12, this intrinsic factor immediately binds to the vitamin B12. And now both of them come to the last part of small intestine, which is called ileum, Now in ileum, in the cells of ileum, we have receptor. The four these receptors are four intrinsic factor plus vitamin B12. And these receptors are sometimes called cobalin cobalin receptors. Okay, now they go through endocytosis process into the inside the cell, and inside the cell, inside the endosome, the intrinsic factor degrades, and now we have free vitamin B12 or mecobalamin. Got it? And now here we have transporter for vitamin B12, and these transporters are called transcobalamin type 1 and transcobalamin type 2 receptors. Okay, 70 to 80% of vitamin B12 binds to transcobalamin type 1, and 20 to 30% of vitamin B12 binds to transcobalamin 1, and they are transported to the blood, and from the blood they're transported to the target tissue. Okay, now this part of vitamin B12 which binds to transcobalamin 1, most part of this goes to the liver, and liver it stores. Got it? Now it will be taken by the target cell by the process of endocytosis. Now in the target cell we have vitamin B12. So now let's see that have vitamin B12 and folate, both of them causes erythropoiesis, causes production of RBC. Not only RBC, for all cells, for replication of all cells, we need vitamin B12 and folate or folic acid. Got it? Now come here. We have folate in in the form 5-methyl tetrahydrofolate. This is very important. Now we will convert. Okay, I'm now going to make a nucleotide. Okay, and some other things. Now we will convert 5-methyl tetrahydrofolate back to tetrahydrofolate. Okay, and in this process we will convert an amino acid which is not involved in synthesis of protein, an amino acid which is called homocysteine to methionine. This methionine is very important amino acid. Okay, so now in this process, an enzyme is called methylene synthase. Methionine synthase enzyme. Okay, so here as a cofactor, vitamin B12 helps this methionine synthase enzyme to convert homocysteine to methionine and 5-methyl tetrahydrofolate to tetrahydrofolate. Now, this is the point. If we cannot convert 5-methyl tetrahydrofolate to tetrahydrofolate, so tetrahydrofolate will be less in our body. Okay, if we don't have enough tetrahydrofolate, come here, we cannot make again in 5 and 10 methylene tetrahydrofolate. And if we don't make this in 5 and 10 methylene tetrahydrofolate, we cannot make purine, adenine, and guanine. So we cannot produce new cell. This is one important point. And if we can't convert 5 methyl tetrahydrofolate to tetrahydrofolate, so this is called folate trapper. We have folate in our body, and this is functional deficiency. We have folate in our body, but we cannot use it. This is called folate trap. Plus. Now come here. Normally, when we change homocysteine to methionine, we use vitamin B12 plus methionine synthase enzyme. So now this methionine is very important. Okay, why? Because we convert methionine in our body in a target cell to another product which is called S-adenosyl methionine. The enzyme is called methionine adenosyl transferase. Okay, it's very important. We convert S-adenosyl methionine to another product which is called adenosyl homocysteine or S-adenosyl homocysteine. And when we convert, listen me carefully, when we convert S-adenosyl methionine to S-adenosyl homocysteine, we release a methyl group which is CH3. And this methyl group is universal donor. We need this methyl group in our body in more than 100 areas for more than 100 purposes. For example, when you want to methylate a DNA, okay, during DNA replication, when you want to change one substance to another, for example, you want to change norepinephrine to epinephrine, you have to add CH3 on it, okay. So this is very important to the target cell, okay. So now this homocysteine or adenosyl homocysteine back converts to homocysteine by the enzyme S adenosyl hydroxylase. Now, this is very important. Now, listen to me carefully. In deficiency of vitamin B12, okay, we cannot convert homocysteine to methionine. We cannot make this thing which is called as adenosyl methionine, and we cannot produce methyl group in our body, and we cannot process uh, a lot of works in our cells, specifically DNA replication. Got it? So now if we don't convert homocysteine to methionine, so homocysteine increases in our body, in our blood, which is called homocystinemia. And homocystinemia is dangerous for different systems in our body, for nervous system, for cardiovascular system, okay, for skeletal muscle system, for so on, and we'll talk about it in the next part, okay. Now, so one function of vitamin B12 is to help as in conversion of homocysteine to methionine, and in conversion of 5-methyl tetrahydrofolate to tetrahydrofolate. This is one function. The second function of, come here to the second function of vitamin B12. First is first. This is homocysteine. We will change in our body homocysteine to a product which is called cystathionine. The enzyme is called cystathionine beta synthase, okay, and the cofactor here is vitamin B6 or pyridoxine, okay. Now we will convert this is very important, listen to me carefully. We will convert cystathionine to another product which is called alpha ketobutyrate, and also plus to an amino acid which is called cysteine, okay. So now in this process the enzyme is called gamma cystathionase plus vitamin B6. Now we will convert alpha ketobutyrate, this is very important thing, to propionyl CoA, okay. Now we will convert, the enzyme here is alpha keto acid dehydrogenase. We will convert after 2 or 3 steps propionyl CoA to a very important product which is called methyl malonyl CoA, and we will convert methyl malonyl CoA to succinyl CoA, and you know about the succinyl CoA, that we use succinyl CoA in Krebs cycle for the production of ADP or energy. Got it? So now come here, okay. I'll tell you vitamin B12, don't worry. We also can convert odd chain fatty acids, for example fatty acid which has 17 carbon, odd number which has, for example, 15 carbon, and so on, plus some amino acids that they are called branching amino acids like valine, isoleucine, and another one is threonine, and so on, plus methionine. We can convert all of them to propionyl CoA. We can convert propionyl CoA to methyl malonyl CoA, and methyl malonyl CoA to succinyl CoA. This is the point. The enzyme which converts methyl malonyl CoA to succinyl CoA, this enzyme is called methyl malonyl CoA mutase. Now, this enzyme needs a cofactor which is vitamin B12 to work properly. So if we don't have vitamin B12, we cannot convert methyl malonyl CoA to succinyl CoA. So what is the problem? The problem is this, that point number one. More methyl, so when we don't convert it to succinyl CoA, so it accumulates in our body. So more methyl malonyl CoA inhibits myelin synthesis. Do you know around the neuron? Okay, for example, this is a neuron, okay, a nerve cell. So this is axon, and this is, for example, and or and part of a bulb. So here around the axon we have a process which is called myelination. Okay, so this myelination is very important for transmission of action potential in high velocity and also for protection of axon. So now during high concentration of methylmalonyl CoA in our body, this myelin synthesis inhibits, and we will talk in next part that degeneration and disease of this neurons, this myelin sheets causes neuropathy, which causes a lot of pain, okay, and numbness, and they will be symmetrical. We will talk about it, and it causes dementia, it causes depression, it causes a lot of problems. Okay, next one. This is one idea about the myelin uh, abnormality. Okay, next one here, come here. This more propionyl CoA also inhibits myelin synthesis. Okay, this also inhibits myelin synthesis. The next idea, if we don't produce methyl group, so now we cannot make myelin, and we cannot do myelination process perfectly. Okay, this is another idea. Got it? Another idea is that high level of methylmalonyl CoA, okay, it incorporates, this is an abnormal fat-like structure, so it incorporates in production and in making of abnormal myelin sheets. Okay, and also it causes destruction of axons. Okay, got it? We talked about homocystinemia, and also if it don't work properly, so methylmalonyl CoA increases in our blood, in our urine. Okay, plus vitamin B12 decreases in our blood. Got it? So this was all about process and metabolism of vitamin B12. This was all about the process and metabolism of vitamin B9, and we saw that how both vitamin B9 and vitamin B12 causes production of new cell. Now, for example, now when RBC proliferates, okay, so cell cycle will continue in normal stage up to end. But when we don't have enough folate, when we don't have enough vitamin B12, so cell cycle stops in, specifically in S phase. Okay, in S phase it stops. We have, for example, G0, S, G2 phase, and then MP phase. Okay, so in step, the cell replication stops, and furthermore RBC do not replicate, and it will come out to our circulation in large size because primary RBCs are large, and that's why it causes megaloblastic anemia. We will talk about it in next part. Okay, it means large cells RBC, and they don't work properly functionally. Okay, that's why they causes anemia. Okay, and a lot of red blood cell also destroys inside the bone marrow. Got it? Now, come here, this small. A daily requirement for vitamin B9 is we need around 400 micrograms per day. In pregnancy, it's around 600 microgram per day. Okay, we absorb it in jejunum, we discussed it, and also it stores in liver around, this very important, around 5 to 10 milligram, and it's enough only for 2 to 3 months, because in signs and symptoms we will talk that folate deficiency causes a lot of problems. It, and also vitamin B12 deficiency causes a lot of problem. We will talk about all of them one by one. About vitamin B12, okay, its daily requirement is around 2 to 4 microgram per day. In pregnancy it's around 2 to 6 microgram per day. We absorb it in terminal ileum, and it stores around 2 to 5 milligram in liver, and it's enough for 4 to 5 years. Okay, so that's why vitamin B12 deficiency is rare, but deficiency of folate is so much and so fast. Okay, and also we'll talk about pernicious anemia, that during the when autoantibodies attack this parietal cell, so parietal cell cannot produce enough, it cannot make enough HCl, and also it cannot make enough intrinsic factor, so we cannot absorb enough vitamin B12, which causes anemia, and this anemia is called pernicious or killing anemia. Got it? So these were all about the metabolism and biochemistry of vitamin B9, vitamin B12, and next part, inshallah, we will talk about the internal medicine part of megaloblastic anemia, the signs and symptoms, the treatment, the diagnosis, and so on. So these were all about the vitamin B9 and B12 metabolism. Have a good time till next lecture.